Welcome back to Mapping Healthcare in Davis, California, where a medic with a map explores healthcare around the world, highlights people who improve it, and shares what we can learn from them. This is your host, Dr. Sheikh. Elena is sitting on the edge of a hospital bed, the paper covering crinkling every time she takes a breath. She's waiting for the results of a biopsy, the kind of wait that makes minutes feel like hours. In the span of an afternoon, 4 different people in scrubs walk through her door. Each one is kind, each one is efficient, but they all introduce themselves in the same way. Hi Elena, I'm one of your providers today. By 4 p.m., Elena is overwhelmed. She has a question about the surgery she might need, a question about her medications, and a question about how she's going to tell her daughter the news. But she doesn't know who to ask. To her, these providers have become a blur of interchangeable cogs in a very large, very expensive machine. She doesn't feel like a patient, which in Latin means one who suffers. She feels like a consumer at a service counter. I've been on both sides of that door, and I felt unsettled by that word too. When we use the term provider, we think we're being inclusive, but we're often doing the opposite. We're stripping away the very things that make our team strong: our specific training, our unique responsibilities, and our professional identities. If we're all providers, then we're just suppliers of a commodity. But healthcare isn't a commodity. It's a calling. It's about compassion, literally suffering with the person in front of you. Elena didn't need a provider. She needed a nurse who understood her bedside needs, a physician who could interpret her pathophysiology, and a physician assistant or a nurse practitioner who could coordinate her complex care. On today's episode of Mapping Healthcare, we're talking about why names in healthcare aren't just labels on a badge. They are signals of relationship, responsibility, and trust. We're going to look at where these names came from and how they shape the people who care for us, and why clarifying professional identities actually makes for a better, safer team. So where did this word provider even come from? It didn't start at the bedside. It started in a government office. The term originated in 1965 with the birth of Medicare. Back then, it was meant to describe organizations like hospitals or clinics that were eligible for reimbursement. It was a word for a billing entity, not a human being. But over the last few decades, that language has drifted. It's moved from the world of commerce into the world of healing. And today, it's used to lump everyone, doctors, nurses, NPs, PAs, into one bucket. Now, on the surface, that sounds inclusive, right? Like we're all one big happy team. But there's a hidden cost. Many clinicians find the term depersonalizing and demoralizing. Think about it. If you're a professional football player, would you want to be called a football provider? Probably not. You're a quarterback, a linebacker, a coach. Those titles mean something. They tell the team and the people watching the game exactly what you're trained to do. In healthcare, when we use business speak like provider, consumer, or billable encounter, we subtly shift medicine from a calling to a trade. Sir William Osler, one of the most influential figures in the history of medicine, said that medicine is an art, not a trade, a calling, not a business. When we lose the names of our professions, we risk losing the ethics that go with them. The idea that we aren't just providing a service, but entering into a sacred, trusted relationship. This brings us to a concept called professional identity formation. Basically, the goal of education for health professionals isn't just to teach you how to do tasks, like how to draw blood or read an X-ray. It's about helping you become a professional. It's a shift from doing to being. This isn't a linear process. It's a lifelong journey that researchers call being, becoming, and belonging. Being is about who you are when you walk through the door. You bring your own race, gender, culture, and life experiences. Becoming is the socialization part. It's where you learn the language of your field, the rituals, and the hidden curriculum. Belonging is maybe the most important part. It's about finding your place in a community of practice. When we use the word provider, we blur the lines of that belonging. The best teams are the ones that value diversity. They don't want everyone to be the same. They want to know exactly what each person brings to the table. Today, we're joined by Dr. Jan Carney, the president of the American College of Physicians. We explore why calling everyone a provider can make teamwork harder because we create role confusion. Patients get confused, and clinicians feel like their specific expertise isn't being seen. So, Dr. Carney, you are the president of the American College of Physicians, or the ACP, and this is the largest medical specialty organization in the United States. It has over 163,000 members in 72 countries. So, today we're talking about a recent position paper that was published in the Annals of Internal Medicine, and the paper is titled Physicians Are Not Providers: The Ethical Significance of Names in Healthcare. And you co-wrote this paper with Lois Snyder-Solmasi for the ACP Ethics, Professionalism, and Human Rights Committee. So let's just start at the beginnings of this paper. Give us some background about what even spurred you and your co-author to write this paper.
So thank you very much for inviting me. And yes, this has been a topic that we've been hearing about for quite a while. And so this came out of the Ethics, Professionalism, and Human Rights Committee. And I chaired this for a couple of years, and I was a member of the committee. And back in 2019, the ACP president began talking about this and actually stood up when he took office and asked all of the physicians in the audience to take the pledge not to use the word provider, because it has been so increasingly used in just common language, and there's a history, and pretty much universally not liked, and it's time to change it.
Yeah, so you've spoken about the background of the organization taking a stand on this, but let's talk a little bit about, maybe your personal experiences. Could you take us back to a specific moment, maybe something you heard in a hallway in your clinical setting, or read in a patient chart, or experienced in a clinical interaction, when the term provider first made you pause or just didn't sit well with you?
So I hear this from colleagues all the time, and actually recently it's escalated, and we have been hearing more and more, and I've been hearing from people here in Vermont, and then all over from ACP and some of our colleagues since we published the paper. But it's been something that I would describe as sort of increasing in um, annoyance in some ways, because it's a word that is does not reflect the nature of our training as a medical professional, and particularly the ethics of our profession. And I'd like to talk a little bit about that, because when we looked at this, sort of the evolution of this term across the board, it really started in the 60s when Medicare and Medicaid federal law passed, and it was a provider of services. And what it really meant was like clinics and hospitals and insurance companies. And it wasn't really designed to reflect sort of what it's being used for now, to everything from physicians to pharmacists to nurses and physician's assistants and physical therapists. Everybody is just called a provider. So let me go back to physicians have lengthy education, 4 years of medical school after college, at least 3 to 7 years of residency, and requirements for all kinds of taking exams to get a credential and a state license, and then ongoing continued education. And it's really, from medical history, been called a learned profession. And that comes back to like the Latin roots for patients, and that relates to suffering. And doctors are teachers, as an example. So those were the roots. But since about the 60s, and it's really escalated since then, it's just broadened in use. And as the configuration of healthcare has changed. So it used to be there are individual physicians and offices in different locations. And now you have big health systems, you have fewer of those small practices, and the organization of medicine has changed. And with this, it's felt that, and everything I hear is that it's deprofessionalized what we do.
Yeah, and you have a background as a physician. You're a physician. You completed med school at the University of Cincinnati, and your residency training in internal medicine at the Medical Center Hospital of Vermont, where you're also a chief resident. And then, in addition to that physician training in internal medicine, you're also both certified in preventive medicine. So, and you have a master's in public health. So you have this really, you have the granular experience in delivery of healthcare services, but you also have a big picture public health systems expertise. And you describe in your paper how this language around using providers didn't just appear, and it evolved along these big changes in healthcare. You spoke about commercialization, system consolidation. So, if you look back over your own career in healthcare as a clinician, how have you seen the language of medicine change in real time? What are some examples that capture that shift clearly for you? So, not just with respect to this specific term that we're talking about today, but just the language of medicine in general.
It really does. This is a great example of how the language of medicine has changed. And if you think about the perspective of and physicians taking care of individual patients and their responsibility for doing that, they have education, and then they have an ethical obligation, right, to do the best they can for that individual patient, to respect that patient's autonomy, to, of course, do no harm. And then when there's not enough resources, which is almost all the time, to do the best you can for as many patients as you can. So that's sort of the interplay between the individual physician's ethical responsibility and those obligations to society. So in the last decades, so the systems part has really changed. So we're seeing those demographics of more big health systems. They might be a hospital with multiple practices, all different kinds of health professionals working there. So that's the thing that I've seen. And I think the language changes kind of parallels that expansion of larger and more, sometimes more commercial health systems. And that's the big concern here.
Yeah, and so, I'm a clinician just like you are, and you emphasize that medicine is fundamentally relational, not a transactional job, right? And that the language that we use can really subtly shape that experience. So think about a patient encounter that has stayed with you, one that really shows this difference between being in a relationship versus receiving a service. And just, tell us a little bit about what about that interaction made it meaningful and stick in your mind?
I have to say, I have to go way back in my own personal experience because this concept really resonated with me first in medical school and then in residency, that how important it was. People are scared. They're in the hospital, they're very ill sometimes, or they come with something they're concerned about, and they're always concerned about the worst. And so, what is really, really important is that relationship that develops sometimes in the moment, but more often over time. And that trust is so important in terms of the individual getting the care that they need and coming back to another appointment, for example. So, that in terms of when I first was becoming a physician, that to me was as important as the textbook knowledge that I was learning or in the classrooms or in the hospitals because they go together. And that trusting relationship with a physician is one of the most important things to improve a patient's health. And that's also what patients want.
And this is really important because you spoke about those formative years of you being a resident where, this change in language or this difference in terminology, all of those things, that raise your awareness there. And you're a professor of medicine at the University of Vermont and you hold many leadership roles there. Like you, I'm a physician who also is in a teaching setting. I'm at the University of California. And so you and I both work with trainees, and you make the case that words don't just describe one's reality. They shape how people see themselves, how they act, how they think. So the language we use, words like, this really gets me, this particular word, non-compliant, really annoys the heck out of me. Or, we see consumer or throughput. Words like this in healthcare can influence what people do or how decisions are made. So, how do you think being called a provider changes the way physicians think about who they are and what they're accountable for, specifically as it plays out in trainees who are learning the profession?
So first think about the word provider. Provider is kind of like you're you're just like anything else. You're kind of a widget, and we're not. And we have different responsibilities, and we have those ethical and professional responsibilities after lengthy education and continuing education. So think about what a provider of services means. So I think about provider of services. A grocery store is a provider of food. And I go in the grocery store and I'm a consumer. And I go in and I put things in my cart and I pay for them. It's a transactional, right? Very, very different, diametrically opposed to what happens in a healthcare environment. And likewise, if I need to buy something online, I would go to an online provider of services and I buy something and I use my credit card. And so it's a transaction. That does not describe that relational aspect that is so needed in healthcare and is part of healthcare. That's the best way I can describe it.
And you wrote this position paper, but of course, every time someone has a position, there's other people with a different position. So these kinds of language shifts that you describe often they come with different viewpoints, especially when we practice team-based care in our healthcare environments. So can you share a conversation you've had maybe with a colleague or a healthcare leader where they disagreed about this terminology. And what did this conversation show about how people see their own roles in healthcare?
So I'm not really seeing any disagreement. I'm seeing agreement. And in terms of individuals, particularly physicians, wanting to be called who they are, and that name is important. And the word physician and provider are not the same. They're not synonymous. Physicians are not providers. So I recently I was invited by a group of pediatricians here to come talk with them at one of their conferences. And we had a conversation around it. And then I got invited to one of the committees in the health system because more people were interested and they wanted to have a conversation about because everything that healthcare, that those relationships, the patient outcomes, putting the patients first, that's what's on the mind of all the physicians that I'm talking to. So I'm not seeing the disagreement. I'm seeing the agreement, whether people contact me online or invite me to have a conversation, want to know about the paper, say thank you. And we want these conversations to continue.
Yeah, and I have a follow-up question to that. You spoke about the general agreement among physician colleagues, but what about colleagues who work in other healthcare professions? What are you hearing from them after this publication of your paper?
I have not heard much as yet, but would welcome those conversations because what we're saying is that it's important and patients need to know who is the person providing healthcare. Who are they? What are their credentials? And providers could be their insurance company and really doesn't tell you anything about the individual who's taking care of you. And so what we recommended, but we don't speak for nurses or pharmacists or physician's assistant. We just said that when describing professionals with different credentials, not physicians, maybe use terms such as healthcare professional or clinicians, but not the provider word.
Got it. And at the heart of your paper, there's a deeper question. What kind of healthcare system and culture do we want to create? And so, if a listener remembers just one idea, one story from our conversation today, what would you want it to be? And how might that change how they speak, how they teach, how they lead tomorrow?
I think that language is important. And to use for physicians, physicians are not providers. And to use the word physician. And I think that's really important to the profession. I also think it's important to that relationship with patients. And I think that patients want those relationships. And that's so important in trust. We talk about now, there is some external confusion about healthcare recommendations and science and things like vaccines and lots of misinformation. It's absolutely fundamental to have a trusting relationship. And we think that that's what you're describing with in that relationship with your physician.
Yes, that is such an important point, and I'm glad that we are closing our conversation with that. We actually end each episode by talking a little bit about, and we're talking about relationships here today, about the relationship that our guest on our episode has to the place they live or work in. And you work in Burlington, Vermont, where you're chief of the Division of Public Health, a professor of medicine, and associate dean for public health and health policy at the University of Vermont Lerner School of Medicine. So tell us a little bit about what makes Burlington or the state of Vermont special and what people who haven't been there should experience.
If you have not been to Vermont, you should come visit us. Vermont is a spectacular place. It is beautiful. It is scenic. It is rural. When you go outside of Burlington and drive around, you see the most incredible fields, mountains, streams, lakes. It's just very, very beautiful. I've lived here for many years now, and what I've always loved is everything. Even I love our state motto, which is freedom and unity, and it describes a lot about our culture here. So I think I'll stop there and say, come visit.
Yeah, and the state motto really resonated with me, freedom and unity. In healthcare, we practice team-based care, and every member of a healthcare team is valuable. And I feel like conveying not just the unity of our profession, but also the unique aspects of what each healthcare professional does is really critical, which in my mind is the essence of your paper. So with that thought, Jan, I really thank you for your time today and for sharing this work around this paper, Physicians Are Not Providers, the Ethical Significance of Names in Healthcare. Thank you.
Thank you for inviting me.
So that was Dr. Jan Carney telling us about why names in healthcare are not merely labels. They shape identity, relationships, belonging, teamwork, and trust. Think about the word compassion. It comes from the Latin compassio, which means to suffer with. It's a word that signals a relationship. Provider, on the other hand, comes from the world of commerce. The vending machine down my hallway is a provider. A person who cares for you is a clinician, a professional. The lesson here is that clarity is a form of kindness. When we are precise about our titles, whether we're a resident physician, an attending physician, a nurse, or a physician assistant, we aren't being stuck up about our credentials. We're being transparent with our patients. We're saying, this is my role, this is my responsibility, and this is how I'm going to help you. It's also a lesson in resilience. Burnout is a huge issue in healthcare right now. Some researchers believe that part of that burnout comes from deprofessionalization. The feeling that you're just a gear in a machine, rather than a respected professional with a unique identity. Reclaiming our names is a step toward reclaiming our joy in work. Before we wrap up, I want to leave you with 3 thoughts, especially if you're someone just starting your journey in healthcare. First, language creates your reality. The words you use to describe yourself and your colleagues shape how you act. If you see yourself as a provider of a commodity, you'll act like a supplier. But if you see yourself as a professional, you'll act with the ethics and the altruism that your calling demands. Second, specific titles strengthen the team. Being a great team member doesn't mean being interchangeable. It It means knowing your unique role and respecting the unique roles of everyone else around you. And finally, healing is relational, not transactional. Patients aren't consumers shopping for help. They are people in need of a trusted partner. Focus on the human relationship and let your language reflect that trust. Thanks for listening. Next time you're in a clinic or a hospital, pay attention to the names and see why communicating them accurately increases clarity about what each of us contributes to a healthcare team. This was your host, Dr. Sheikh. Connect with me on Instagram at Mapping Healthcare. If you enjoyed this episode, please leave a review.